Recording.
Okay, shall start then. A very good morning, everyone. Thank you for joining on our year-end webinar series for the year 2024, organized by our Neuroemergency Special Interest Group. I'm Dr. Vilashni Sinea, an emergency physician who are currently attached to Hospital Sultan Abdul Halim. Very delighted as an emergency physician to be a moderator for the webinar session. Today, we will be having two interesting topics presented by our wonderful guest speakers. Before I introduce our guest speakers, let me brief through our itinerary for the next 2 hours. We will first start with the topic by Dr. Chan Yin Yi, emergency physician from Hospital Tengku Aminah, followed by Dr. Nina Nasrina, and each section will run for an hour. I encourage actively the participant to ask question at the end of each section, preferably either direct or you can type in into your chat box. Sorry. Now, without further ado, let me introduce our first speaker for the day, Dr. Chan Yin Yi, who currently attached to Hospital Tengku Aminah Klang as a clinical toxicology trainee. She holds a master's degree from the USM, graduated in year 2017, started her career as an EP at Hospital Malacca. Her immense interest in toxicology with a great mentor, Dr. Aisha, has driven her to pursue her dream in respective field. She has made a significant contribution to toxicology field by presenting various oral presentations and posters and also participating in the conference, both local and Asian level. Without further ado, I will hand over to Dr. Chan Yin Yi to present her topic on forgetting toxicology emergency. Dr. Chan, the floor is yours.
Thank you. Okay, I'm actually honored being invited to give a talk in this webinar. So, okay, I think we don't waste time. We shall proceed with the presentation. Let me share my screen, yeah. Yep. Can everyone see my screen?
Clear, Dr. Chan.
Yeah. Is my...
Maybe you want to show in a slide
Slowly.
presentation?
Okay, my slide is moving, right?
No, it's, yeah, good.
I already show in the slide presentation.
Yeah, all good.
All good. Wait, I
Yeah.
think my internet is not so stable now. Hello? Wait,
We can hear you, Dr. Chan.
Okay, you hold on for a while lah. Because my internet is not so stable. I try to change my internet. Sorry for the technical issue. Wait. Okay, hello. Can anyone?
Yeah, good.
Yeah, I'm going to share my screen again. Yeah. Okay, can you see my screen?
Yes, yeah, can, Dr. Chan.
Okay. Okay. Good morning, everyone. I was given a topic. Actually, I tried to prepare this lah. So we're going to talk about delirium tremens now. Okay. So delirium tremens, the forgotten toxicology emergency. Okay. So this actually is one of the first book we call as a natural historia. Actually, it's called a natural history by this Pliny the Elder. In the first century of the BC, actually he described the alcoholic and the alcohol withdrawal as follow lah: the drunkenness, bring pallors and sagging cheeks, sore eye and trembling hands that spill a full cups, of which the immediate punishment is a haunted sleep and an unrestful night. So these are the first person who described how alcohol withdrawal in an alcoholic person. Okay, so in the initial treatment that's described by this Osler at the turn of the 20th century for the alcohol withdrawal syndrome is supportive care, which including the confinement to bed, cold bath to reduce the fever, and judicious use of potassium bromide. They even use chlorohydrate to sedate the patient, hyoscine, and possibly that they use opium at that time as well. So throughout the years, actually the treatment of alcohol withdrawal is start to evolve, okay? So delirium tremens is actually a severe form of alcohol withdrawal. Alcohol withdrawal actually is a spectrum. So starting from mild, moderate to severe, and then it will progress into like the most severe form, which is this delirium tremens. If we don't treat the patient, the mild form actually can progress into a severe form. So this severe form actually is characterized by sudden and severe mental or nervous system changes. So why is it a forgotten emergency? As you will can see that there's a shift in alcohol consumption pattern. So declining in alcohol consumption in some of the population, some country actually maybe it's a religious causes, they actually reduce their alcohol consumption in the population. And also throughout the years, we can see that there's a changes of a substance abuse trend, such as people are stopped abusing alcohol, they are abusing other substances such as opioids, cannabis or synthetic cannabinoids, and synthetic drugs. Okay, so another reason is under recognition in a healthcare setting. Why? Because we are getting lesser to encounter alcohol withdrawal. So it decreasing the familiarities in a new generation of the physician. And alcohol withdrawal syndrome, it mimics in a lot of conditions like sepsis, like NMS. So it mimics in a lot of conditions. So the complex diagnosis actually make it under-diagnosed or under-recognized. And then the next reason is like the rise of the preventive measure. So early identification and treatment of alcohol withdrawal also make alcohol withdrawal less being seen by our physicians nowadays. And then now it's like competing. Another reason is a competing medical emergency, because emergency of a new priority in toxicology and emergency medicine. We have other new emergency in the toxicology fields and the emergency field. And then the pandemic COVID-19 and the new focus on the mental health. That's why a delirium tremens sort of being neglected. That's why it's a forgotten emergency. Okay. So incident and prevalence about delirium tremens is occurred in about 5% of alcohol withdrawal cases. And estimated mortality rate without treatment is 15 to 40%. Actually, it's very high. So with a proper treatment and a supportive care, actually we can reduce the mortality rate into 1 to 4%. So recent study has shown there's a rise in alcohol misuse during the COVID pandemic lockdowns, which will increase the delirium tremens risk. So in a 2023 review reported in an incident rate about 1.7% among hospitalized patients with alcohol use disorder. So what are the pathophysiology behind this alcohol withdrawal syndrome? So one of the proposed pathophysiology is the GABA and the NDMA dysregulation. So when a person exposed into a chronic alcohol exposure will lead to downregulation of the GABAergic inhibition and upregulation of the excitatory NMDA receptor. In our brain, actually, we have GABA, which is an inhibitory neurotransmitter. And then we have this glutamate as well. Glutamate is an excitatory neurotransmitter in our brain. So chronic use actually will cause this dysregulation of these two neurotransmitters and then cause a symptom when the patient have stopped or ceased using the alcohol. So abrupt alcohol cessation will trigger unopposed NMDA activity, will cause a CNS hyperexcitability, which we can see all in the patient when the patient develop an alcohol withdrawal syndrome. So when a patient in withdrawal, we can see the catecholamine surge or adrenergic surge in a patient. So like a heightened noradrenaline and dopamine activity will lead to autonomic hyperactivity, such that we can see the patient when in withdrawal state, the patient can have sweating, tachycardia, hypertension. Some will have severe psychomotor agitation. So some study has actually shows that chronic alcohol usage will dysregulate the function, the stability of the neurotransmitter, and even causing some brain changes. So some structural changes can occur in the hippocampus, and the prefrontal cortex has been linked to persistent cognitive deficit that is seen in a severe alcohol withdrawal patient. So that a newer hypothesis says that maybe there's some neuroinflammation. So recent research has shown that a neuroinflammatory marker, the cytokine like interleukin-6, may be contributing to the symptom of severity. So targeting these markers could be present as a new treatment in alcohol withdrawal syndrome. But this is just a very, very new hypothesis. So we need more research to show that whether this actually can contribute to one form of treatment in alcohol withdrawal syndrome. So what are the clinical presentation? So like I said earlier, the delirium tremens actually is the severe form of alcohol withdrawal. So usually it will occurring about 48 to 96 hours after the last alcohol intake, but it can present up to 10 days after cessation in some cases. The clinical features are typically a progression of a withdrawal syndrome that is worsened if not really treated properly. So untreated delirium tremens have a fatal outcome up to 30% of the cases. So what are the timing of alcohol withdrawal syndrome? Like I told earlier that the alcohol withdrawal syndrome actually is a spectrum. It's starting from a minor or mild, then subsequently moderate. So it's actually based on the onset of the last drink actually can tell us the symptom progression. So it's like if in the minor withdrawal, the patient will appear like a little bit tremor, mild anxiety, can have headache, palpitation, GI upset, okay? It occurs about 6 to 36 hours after the last drink. And the more severe form, actually, the patient can develop seizures. We also call this as alcoholic withdrawal seizures. So single or brief burial or GTC seizures, short post-ictal period, status epilepticus usually is rare in alcohol withdrawal syndrome. And then patient can develop a status called alcoholic hallucinosis. So patient can have visual, auditory, or tactile hallucination with intact orientation and normal vital sign. So delirium tremens can cause delirium, agitation, tachycardia, hypertension, fever, and dysphoresis. So I got this actually from Up to Date. If you all want to read further, you actually can go to Up to Date. So what are the common signs and symptoms that we encounter in delirium tremens? Actually, delirium tremens, which is like confusion, disorientation, can occur in 80 to 90% of the patient we experience in delirium tremens, experience severe confusion, disorientation, and impaired attention. So this cognitive disturbance can fluctuate throughout the days. So the prevalence actually 80 to 90%. So you can see also autonomic hyperactivity, which is like tachycardic hypertension. So tachycardia, you can see over 90% of the DT. And hypertension occur in about 50 to 70% of the cases. Fever usually is low grade, but can reach up to 40 degrees in severe cases. Sweating, pallor, tremor are seen in nearly 100% of the delirium tremens cases as part of the hyperadrenergic response. As you can see that all this actually is similar like a sympathomimetic type of tox syndrome. So that's why I say that the delirium tremens sometimes is mimicked in other conditions. That's why it's under-recognized. Like psychomotor agitation and hallucination can occur in 50 to 60% of the delirium tremens case, and visual and auditory hallucination occur in 25 to 75% of the patient, which experience visual hallucination, often seeing insect or small animals. Seizure usually appear as a generalized tonic-clonic seizures. clinical studies suggest that the seizure, if occur in a delirium tremens patient, increase the risk of mortality and complication. Of course, if the patient have prolonged use of alcohol, that maybe they will suffer with electrolyte imbalance, dehydration, malnutrition. So electrolyte disturbance are seen up to 70% of the delirium tremens patient, which will contribute to the risk of cardiac arrhythmia and muscle weakness. So the most common electrolyte that we can see is hypomagnesemia, hypokalemia, that see in the severe delirium tremens patient. The hypothermia and sweating, up to 50% of the patient can experience hypothermia, which may further complicate the clinical course. So by leading to dehydration and electrolyte imbalance, or if very, very high grade temperature, like we dealing with heat stroke, patient actually can develop a multi-organ failure, and patient can develop rhabdomyolysis as well. So the differentiation of acute alcohol from other events that altering the conscious level, like I told you that there's a few differential diagnoses. So like Wernicke syndrome, if related to alcohol intake, trauma like subdural hematoma, sometimes hypoglycemia, hepatic encephalopathy. So these are the few differential diagnoses that we actually can take it in mind. So diagnostic criteria for alcohol withdrawal syndrome is we need to have a cessation of or reduction in alcohol intake, which has been previously prolonged or heavy. So if with the criteria A plus any of the two of the following symptoms develop between several hours to few days. So like anxiety, autonomic hyperactivity, hallucination, insomnia, tremor. So the above symptom will cause clinical significant distress or impairment in social, occupation, or other important areas of the functioning. These are the diagnostic criteria. So maybe if you're in, actually I got this from my girlfriend, clinical toxicology emergency book. So if you're, whoever have more interest wanted to read, actually I can share the book as well. So when the patient develop alcohol withdrawal syndrome, one form of it actually we want to decide how severe is it. So we have like using some scale to determine the severity grading. So the most commonly used for alcohol withdrawal is this scale called Shiva, Clinical Institute Withdrawal Assessment of Alcohol Scale. So most commonly used to assess the severity of the alcohol withdrawal symptom. It limited by the requirement of subjective assessment by the patient that cannot be adequately performed in highly agitated or sedated patient and are difficult to use in a situation with language barrier. Usually severe form of delirium tremens, the patient might need a mechanical ventilation. So the assessment, if the patient is intubated or sedated, is difficult to use this score. So another score that we usually use actually is a Richmond Agitation Sedation Scale. So these are more observer-based, does not directly measure but it does not directly measure the alcohol withdrawal symptom. So this scale actually best to use in conjunction with other tools such as the previous score that I mentioned. And this scales is widely used in ICU, not only in alcohol withdrawal syndrome or delirium tremens. Basically, this scale actually is widely used in ICU for all those patients who develop deliriums. So these are the two scores. As you can see that the CVA score actually has a lot of component in it. So it will take more time to assess the patient. And the other side actually is a Richmond Agitation Scale. So next we'll talk about who will develop delirium tremens. So what are the risk factors? So I divided into like few category lah. So the first will be related to the general patient's factor and medical history. So age greater than 65, who have concurrent illness, comorbid medical or surgical condition, especially traumatic brain injury, physiological dependence on like GABAergic agents such as like chronic use of like benzodiazepine. So this patient actually has higher risk to develop delirium tremens. So another factors is that related to the past alcohol-related illness. If the patient have long duration of heavy and regular alcohol consumption, and previously has a numerous episode of alcohol withdrawal, or history of alcohol withdrawal with deliriums or seizures, or history of having delirium tremens, all these patients actually had higher risk of developing delirium tremens. And then the factors that related to current illness, such as like significant sign and symptom of alcohol withdrawal in the presence of elevated blood alcohol concentration, which means that when you send a serum ethanol, actually that's a measurable serum ethanol, but the patient is still having alcohol withdrawal syndrome. A longer period since the last drink. So such as a patient who present with the alcohol withdrawal more than 2 days after their last drink are more likely to experience DT than those who present within 2 days. So the seizures during the current withdrawal period and marked autonomic hyperactivity on presentation also will one of the risk factor for patient to develop delirium tremens. So this is another scoring actually to score the alcohol withdrawal, okay, that being used. So next, I would talk about the treatment. So when we encounter a delirium tremens, of course, we want to exclude alternative diagnosis. Like I told earlier that alcohol withdrawal syndrome can be made in a lot different kind of condition. Okay, so we try to treat the patient in a quiet and protective environment. Of course, supportive care is the ultimate important part of it. So we give IV fluids and then nutritional supplementation and frequent clinical reassessment is a must. So as we all know that chronic alcoholic user that tends to have a thiamine deficiency. So supplementation with thiamine and glucose should be given to the patient to treat the wernicke encephalopathy. And multiple electrolyte imbalance, we should correct it so that to reduce the complication of cardiac complication. And the last, of course, we want to treat the psychomotor agitation. Okay, so how to treat this psychomotor agitation? So the first line, I will suggest that we use a benzodiazepine. So to treat a psychomotor agitation and prevent the progression from minor withdrawal to the major one. So what are the type that we can use? As it's available to us is diazepam, lorazepam, midazolam actually are frequently used. But we prefer using those long-acting benzodiazepine with active metabolite, which such as Valium, diazepam. Okay, lorazepam, the mechanism is shorter acting and it does not contain active metabolite. So this agent usually we keep it for the patient with advanced liver cirrhosis or acute alcoholic hepatitis. So how to give? So we actually in UpToDate they actually propose like two approach. So one is symptom trigger approach, which is used in most of the patient. We provide medication when patient has symptoms only. But this downfall is you need a regular assessment for the patient status and you try to use a validated instrument such as Shiva to assess the patient frequently. So the benzodiazepine are only administered every hour as long as this score actually remain greater than 8 to 10. So you can start loading the patient with like 5 to 10 mg and then you can reassess the patient in 5 to 10 minutes later and see whether the patient symptom actually improving or not. If the patient still not improving, then you can top up another 5 or 10 mg until you reach a certain state that the patient is sort of like calm or lightly sedated. So another approach actually is called a front-loading approach. Usually this approach is slightly more aggressive. Why? Because we usually use this in a patient who has greater risk of complication from prolonged period of hypertension and tachycardia, such as an elderly patient or the patient have underlying cardiac problems. So they will have more risk to develop complication if we leave them in a prolonged state of a hyperadrenergic state. So usually diazepam or Valium can be used in 5 to 10 mg every 5 to 10 minutes until appropriate sedation is achieved. Then of course, after you achieve the sedation, you still need to do a frequent assessment to the patient. Maybe you might need to top up with the benzodiazepine to control the psychomotor agitation. What if you encounter after you give a large dosage of benzodiazepine and yes, the patient still in alcohol withdrawal and delirium tremens? So we actually have other agents that can be used, but we don't propose to use it as a first line. So once you have achieved a high doses of benzodiazepine, you can actually consider to give a phenobarbital. So usually it's given in a combination with benzo. The IV doses can go up to 260 mg is recommended. But if you reach this state, of course, I prefer that you can get a consultation from us first. Okay. So another agent that we propose to use actually is propofol. It's either used in a bolus or in an infusion form. So in an ICU setting, they usually started with a dosing regime of 10 to 5 microgram per kg per minute. So this can serve to adjunct to a benzodiazepine for patients with resistant alcohol withdrawal. But what you have to be cautioned when you're using these two agents, because the use of propofol and barbiturate is a very narrow therapeutic index. So there's a potential the patient might develop a profound respiratory depression. So these are the caution that you have to keep in mind when you decided to use these two agents on top of the benzodiazepine. How can these two agents actually help? So both of these actually can act synergistically with the benzodiazepine to enhance this GABA-induced chloride channel opening. So in addition, the propofol also antagonizes this NMDA receptor, thus will reducing the excitatory component of the alcohol withdrawal. So of course, we have other therapies that is being suggested. So like ethanol, because the patient is alcohol withdrawal, right? So it's a sort of a logical sense that you give out ethanol to the patient, which is alcohol, then we will actually ease the alcohol withdrawal syndrome. But usually we don't recommend to do that. Why? Because ethanol, different patients actually have different level of tolerance and different level of dependence to ethanol as well. So the effect of it can be unpredictable and that might cause other complications. So some actually suggest to use this adrenergic antagonist like beta blocker, clonidine. Even we use this Presidex, okay? But all these are actually not really clinically proven. It's just like by theoretical, we think that this might work. So we still need more research to tell us or to recommend the routine use of this agent in alcohol withdrawal patient. Because currently the clinical data case report actually have controversial or different result in using it in alcohol withdrawal syndrome. Magnesium, as we know that magnesium, we can use it for hypertension in a pre-eclampsia or eclampsia patient with come with seizures. So magnesium actually can be used, but we don't recommend routine use in delirium tremens for the patient, but more we will suggest to use magnesium in electrolyte imbalance that you need to correct, then you give magnesium. So some actually propose about anti-epilepticus such as like carbamazepine. The result also is sort of controversial, so we still will suggest that we use this anti-epileptic case-to-case basis. Gabapentin, baclofen, and ketamine also is being suggested as part of the therapy in delirium tremens or alcohol withdrawal syndrome. Okay, so last will be the disposition. So of course, in a severe form, we suggest that actually patient being monitored in the ICU setting. So these are the actually suggested criteria that I take from this up to date. So for ICU admission with alcohol withdrawal, you can go look into it in detail in up to date. Okay, these are my reference. I took it from Frank Toxicology Emergency 11 edition, up to date for alcohol withdrawal and critical care and clinical toxicology. Thank you. Any questions that you all want to know more about?
Thank you, Dr. Chan. That was a highly remarkable and pleasant presentation. I would like to open to the floor. Is there any question?
Yes, I have a question to Chan.
Yes. Yeah.
Oh no!
Okay, Chan, I would like to ask because delirium tremens is related closely to the alcohol intake, right? So
Yes.
yeah, when you're taking history to the patient, because when you look a patient coming in with fever and hallucination, the first thing we'll think of is probably this patient is
Negative.
having meningoencephalitis. That's the
Yes,
first thing,
true,
right? So
true.
in terms of the history taking, how would you suggest for us to take that? When you mention history of heavy alcohol intake, how do you define the heavy alcohol intake? Like how many times per week or how many intake per day that can define that? And the cessation from this last alcohol intake to the development of potential delirium tremens condition.
Okay, so the alcohol intake history actually we have to take. There's a criteria of the heavy usage of alcohol, and so I'm sorry. I have to apologize that I didn't memorize it. Usually when I want to take alcohol history, usually then I will Google it up, the how many unit, how many ounce, and like how like use it per day, and so there's a definition of a heavy usage of alcohol. So, and then the cessation of alcohol intake actually very important if you want to diagnose a delirium tremens. That's why one of the part of the treatment I emphasize is you have to exclude other alternative diagnosis. So if the patient come in with like high grade fever, like autumn mental status, of course, the first thing that we're thinking about CNS infection. So for me, by all means, actually, you can treat. If the patient have history of chronic alcohol intake, heavy alcohol intake, and then you suspect that there's a component of delirium tremens, actually, we can supplement with the thiamine and then control the agitation with benzodiazepine. To tell the truth, if the patient who come in with acute delirium, regardless what are the cause, the first line will be benzodiazepine. If you're asking me from the clinical toxicology perspective, because there's other substance that can actually cause autonomic status, if you try to use like antipsychotic to like as psychiatric love to use their antipsychotic in agitation patient or delirium patient, I don't recommend that. Why? Because you do not know whether the patient actually is on psychiatric medication and that patient currently is in neuro leptic NMS syndrome. So if you top up with the antipsychotic, you might worsen the symptom. So as from the clinical toxicology perspective, all agitation or delirium, regardless what are the cause, I still feel that the safest drug actually is benzodiazepine. So like just now, Dr. Rasiri asking if the patient come, the first thing that we're thinking about CNS infection, by all means, actually we can treat. So if you think there's a component of delirium tremens, you can top up with like thiamine, and then you can control the agitation with the benzodiazepine.
Dr. Chan, I have
Yes.
one over my side. Is it
Yep.
okay? Dr. Chan?
Yes, can you
Yeah.
hear me?
Yeah. How would you, the cause of the delirium tremens typically progress over the years, over the time?
Yes, over the time, correct.
Ah. How they progress? Will they have a recurrent admission or?
Okay, actually, alcohol withdrawal syndrome is a spectrum, which means that when the patient develops symptom that time, they usually start with the mild symptom. And how to say, usually alcoholic, they know when they are in mild withdrawal, then they will go and take more alcohol. So that will
Mhm.
ease their symptom. But when they come to the hospital that time, if we don't treat it, the agitation, and we don't give a good supportive care, they can progress from mild to moderate, and then subsequently in a severe form, they subsequently develop the delirium tremens. Okay.
Yeah.
So if the patient have history of develop and delirium tremens, the patient actually can develop again in the future. So which means that if we treated the patient and the patient clinically well and go home, but he's still abusing alcohol,
Mm-hmm.
then the patient can actually develop alcohol withdrawal syndrome in the future.
Okay. Yeah, I want to share my experience when I had a case back in my hospital. Actually, this
Okay.
patient was admitted for seizure for investigation
Okay.
by my night team. And
Mm.
during my morning rounds, I noticed this patient. I just spent a little bit more time and clocked the history again. And while I was clucking, I clinically he was a bit malnourished and everything. And I just
Mm.
asked, "Do you consume alcohol?" Then his face grimace changed really. He become a little agitated. Then I was like, been going in deep. Is this the brand that you take? And this is usually how much the volume? Suddenly he just threw into fit.
Okay. Fit, you mean seizures, is it?
Yeah, I think then I think I re-diagnosed as a round fit.
Yeah, round fit actually. Okay, like just now I mentioned about the spectrum of the alcoholic, right? So actually round fit is an alcohol withdrawal seizures. So if the patient develops seizures, we don't diagnose the patient as delirium tremens yet, because
Okay.
delirium tremens, right? The patient have to
You?
have some form of auto mental status.
Yes.
So yes, if you are putting it as a round fit, which is alcohol withdrawal seizures.
Okay.
Yeah.
Thank you, Dr. Chan. Yeah, is there any other question, team? Okay, there's one in the chat box. Okay, do you suggest empirically cover for sepsis or meningitis as delirium tremor signs and symptoms mimic sepsis? And for patient with hypertensive and tachycardia and delirium tremors, do you suggest using antihypertensive drugs to avoid complication? Example, acute pulmonary edema and intracranial bleeding.
Okay. The first question first. Wait, the first question. Wait.
Do
Can I
you
stop
empirically
share
cover?
my wait. I found the checkbox.
Okay.
So the question is like empirically cover for sepsis or meningitis. At the end of the day, I will still say that it comes back to the history taking and physical examination. So if the patient have a meningitis sign like neck stiffness, and so by all means we treat as meningitis. So if you think that this patient actually can give you some infective markers that which is positive, then you think that this is more likely to be an infection, yes, go ahead and treat the infection. So this is a tricky part about alcohol withdrawal or delirium tremens in a severe form that will mimic a lot of condition, and we don't have a test to confirm our diagnosis of delirium. So if you have a doubt of this patient might in sepsis or infection related, treat the infection. Okay. If the patient comes with hypertensive and tachycardia in delirium tremens, you ask me, do I suggest to use antihypertensive to avoid complication? Remember, I told you that just now the one of part of is the hyperadrenergic surge, right? So the agitation, the agitation actually can, and the hyperadrenergic state actually can contribute to the hypertensive and the tachycardic in delirium tremens. So if you are hydrating the patient, adequate hydration actually can bring down the tachycardia. And then proper sedation, actually you can bring down the heart rate and the blood pressure as well. Because delirium tremens, sometimes the patient is agitated. So all this agitation actually can contribute to the adrenergic surge as well. So the hypertensive and tachycardia can usually be bring down just by the hydration and the proper sedation itself. So if the patient is still uncontrolled with all this matter, then I might consider with using the antihypertensive. But that will be the last resort. The first will still control the agitation because we still think that the agitation can contribute to this hypertensive and tachycardic. Hope I answered the question.
Yeah, I suppose it's a great explanation. Okay, is there any further question? Okay, if not, thank you very much, Dr. Chan, for your wonderful speech today. I shall move for the next talk. Ina?